Hello. If you've ever felt frustrated by a patient with persistent urethritis or cervicitis that just won't clear, you are likely dealing with the harbinger of the antimicrobial resistance crisis, Mycoplasma genitalium. A recent supplement in Open Forum Infectious Diseases outlines a practical approach for clinicians to manage what has become an increasingly refractory infection. Today, we're going to walk through the standard of care, the biology of resistance, and the salvage strategies you can use when the first-line treatments fail. Step 1. Understanding the biology. The first thing every clinician must remember is that MGen lacks a rigid cell wall. This makes all beta-lactams, your penicillins and cephalosporins, completely ineffective. We are restricted to antibiotics that target protein or DNA synthesis, macrolides, tetracyclines, and fluoroquinolones. Step 2. The two-stage standard of care. The current CDC gold standard for treating MGen is a staged approach. We no longer recommend starting with azithromycin alone. Instead, we use a 7-day lead-in of doxycycline, 100 mg twice daily. Why? Doxycycline doesn't usually cure MGen. Its cure rate is only about 30 to 40%, but it effectively reduces the bacterial load. This reduction makes it much easier for the second-stage antibiotic to clear the remaining organisms, and crucially, it reduces the risk of the bacteria developing de novo resistance during the second phase. After the 7-day doxycycline lead-in, your choice depends on resistance testing. If the strain is macrolide sensitive, follow with a high-dose azithromycin course, 1 gram on day 1, followed by 500 mg daily for 3 more days. If the strain is macrolide resistant, or if testing is unavailable, follow with moxifloxacin, 400 mg once daily for 7 days. Step 3. Navigating the resistance crisis. Management is getting harder because resistance is no longer the exception. It's becoming the expectation. Macrolide resistance. Globally, this is over 33%, but in many U.S. sexual health clinics, it exceeds 50%. It's driven by single nucleotide polymorphisms at the 23SRRNA gene. Fluoroquinolone resistance. This is also rising, currently around 13% globally. It's primarily linked to mutations in the PAR-C gene. Here is a practical clinical pearl. If a patient has concurrent mutations in both the PAR-C and GIR-A genes, the risk of moxifloxacin treatment failure nearly doubles. While we don't have widely available commercial tests for these specific mutations in the US yet, a failure of moxifloxacin after a doxycycline lead-in is a strong clinical indicator of dual-class resistance. Step 4. Salvage strategies for refractory cases. So, what do you do when doxycycline followed by moxifloxacin fails? This is where you have to move beyond the standard guidelines and look at salvage options. Minocycline. This is a powerful repurposed option. Studies show that a 14-day course of minocycline, 100 mg twice daily, achieves a microbiological cure in about 71% of macrolide-resistant cases. It is often better tolerated than other salvage drugs and is widely available. Minocycline plus metronidazole. If you are treating cervicitis or pelvic inflammatory disease where co-infection or anaerobic involvement is suspected, this combination has shown cure rates of around 80%. Citalfloxacin. While not yet FDA approved in the US, citalfloxacin has shown a 70% success rate even in patients who have already failed moxifloxacin. It's an important agent to watch in the development pipeline. Pristinamycin. Common in Europe and Australia, but difficult to access in the US, this drug has a 75% cure rate for multi-drug-resistant MGen. Spectinomycin and tinidazole. Emerging case reports show success with high-dose tinidazole or intramuscular spectinomycin for 7 days, particularly in multi-drug failure scenarios. Step 5. Special populations. Pregnancy and partners. Testing and treating in pregnancy is uniquely difficult because both doxycycline and moxifloxacin are generally contraindicated. If the MGen is macrolide sensitive, azithromycin is your only safe bet. If it's resistant, you must engage in shared decision-making with the patient, often delaying definitive treatment until after delivery if the patient is asymptomatic. Regarding partners, concordance is high. If your patient is positive, their partner likely is too. While the data on partner treatment reducing reinfection is still emerging, the current expert recommendation is to notify, evaluate, and consider treating the partner with the same regimen used for the index patient to prevent the ping-pong effect of reinfection. Conclusion: setting expectations. The most important practical tool you have is communication. Patients with refractory MGen are often frustrated. Be transparent about the limits of current testing and the rising rates of resistance. In the US, we are still waiting for FDA-cleared resistance assays for macrolides and fluoroquinolones to become standard. Until then, the staged doxycycline to moxifloxacin approach remains your best first line. If that fails, minocycline is your most accessible salvage tool. For a detailed look at the dosing tables and the emerging antibiotic pipeline, I encourage you to read the full review in Open Forum Infectious Diseases. Thank you for your dedication to tackling this challenging infection. Keep advocating for the diagnostic tools your patients need.